My name is David Armstrong. I'm the director of the Health Workforce Tactical Assistance Center. And today's event is co-sponsored with the National Forum of State Nursing Workforce Centers. It is entitled Barriers and Challenges to the Clinical Placement of Nursing Students. And with that said, let me go ahead and introduce today's meeting facilitator, Marcia Proto. Marcia is the executive director of the Connecticut Center for Nursing Workforce. Marcia?
Thank you, David. Welcome, everybody, and good afternoon. I'm located in Connecticut, so those of us who are on the East Coast, it's afternoon, and those of us who are on the West Coast, it's morning. But I can't thank you enough for participating today. When David initially sent out the announcement, I heard the 60 spots filled up so very quickly and clearly opened this up for a much wider audience. And I think we had over 100 register, so couldn't be more excited about the topic. And as David alluded to, we're just not going to talk about barriers and challenges. We really want to talk about solutions and strategies. So David invited me today to really share a brief overview of what we've been doing in Connecticut. We're an extremely small state. As executive director of the Workforce Center, many things that would be undertaken by our hospital association or maybe our board of nursing or public health, because there's just so few organizations, really kind of get split between the Connecticut Center for Nursing Workforce, and if it's regulatory or legislative, goes to our nursing nurses association. So this is why I guess our Workforce Center is kind of in the middle of a lot of these conversations regarding clinical placements in the state of Connecticut. So again, thank you, David and your team, and Matt and Tricia for pulling this together. And on behalf of the forum, I know we're very excited to be partners in this session today. It's been a hot topic for most of our states who are members of the National Forum. And I think this is a wonderful way to cross-pollinate with folks that we don't see on a regular basis. So really welcome this open dialogue. Just to share with you a little bit about what we have done in the state of Connecticut to address clinical placements. I used to work at our hospital association 30 years ago, and it was the same conversation. And so when I came to the Workforce Center, but we were the Connecticut League for Nursing at the time, back in 2005 and 2007 and 2009, and finally in 2011, I said, you know what, if we can't slay this beast of clinical placements, observations, as well as capstones, we're really in trouble. So as a collective with the Connecticut Hospital Association and the Connecticut League for Nursing, we decided to put out an RFP to all of the major players across the country who offer clinical placement systems. We really wanted to find out what was out there, what were the capabilities, but more importantly, what were the costs. Based on the RFP, we received 6 responses. Our co-group of Hospital Association nurse educators and our deans and directors reviewed the proposals that came to us. And then we said, you know what, it looks like only 3 meet our needs. We actually invited them in and hosted them at the Hospital Association, but also at some of our schools. What we found out was to carry a system statewide for all of our schools and our practice facilities, and we were just looking at hospitals at the time, it would cost us about $150,000 a year. In the 2 models we were looking at, one was paid by hospitals. So the schools were cheering and saying, great, we don't have to levy this for our students. And then in the other model, the schools paid for the system. So the hospitals were thrilled. We don't have to expend any resources. So bottom line, as a group, we got together and said, you know what? Let's build our own proprietary system. So we stood up the system in 2014. We had a small pilot group, Stanford Health, along with 4 schools of nursing, were the pilot. And we were just feeding the beast and kind of organized their placements. Stanford Health would list everything they had available, not only in their bricks and mortar, but community and outpatient. And our schools who had contracts them would go out and grab them. And we'd actually be able to look at the capacity of Stanford Health related to the RN placements. We did not do LPNs or NPs or any other roles. We had the associate, baccalaureate, and accelerated students. Fast forward a few years, the Hartford healthcare system with 11 bricks and mortar hospitals, including standalone Institute of Living, Natchog Hospital, behavioral health, came aboard. So all of a sudden, we brought on 12 major facilities in the state of Connecticut with 18 of our schools of nursing at the RN level. What we did find out, and this goes, Joy, to your comment earlier, we were always under the misconception that our clinical placements really were constricted by what our hospitals could give us, as the NCLEX was so hospital or acute care focused. Now it's a little different. But what we found out was Hartford Healthcare System posted 4,000 student seats for clinical experiences, but our schools who had contracts with them only grabbed 2,800. So all of a sudden, our preconceived notion that we had so many more students needing placements versus what was available was kind of a misnomer. Yet, some of those placements, because it was a directive by the System Professional Development VP, said, I want all of your placements. So some of the big hospitals say, we work 24/7, 365. They put those placements for nighttime. But what it did bring aboard was, and David, you mentioned this earlier, the hospital realized that if they were going to get students into these alternate clinical rotations, they needed to take responsibility of growing their own clinical faculty. So all of a sudden, the conversations began to be a little different. In addition, at the same time that our organization was working on that, we have an entity called the Office of Workforce Strategy in Connecticut that was just brought aboard about 4 years by our governor. This is where all the ARPA funds and federal funds for healthcare and workforce development and those impacted by COVID are being funneled. So the Office of Workforce Strategy had an RFP for a lot of different innovative healthcare opportunities to build pipelines, to work on clinical placements, and to build partnerships. And in addition, Connecticut even got additional dollars for workforce development. So we created what was called the Connecticut Health Horizons program with $26 million focused on nursing education. So in addition to when we open this up to talk about your challenges and barriers, we'd love to hear your solutions. You know, we have just a few, I'm sure you have so many, but we also want to talk about what funding sources may exist within your state that you may be aware of or not aware of. So the Connecticut Center for Nursing Workforce has been fortunate because our Office of Workforce Strategy is actually going to fund verbally, I haven't got the contract yet, a 3-year project to scale our proprietary clinical placement system statewide. For RNs, we're going to onboard the LPNs and the NPs over time, focusing on hospitals, but then moving to our long-term care, home care, and community care. So we are going to be getting about $281,000 over 3 years, specifically, so we can really assess what is our capacity. Because until we have the capacity for placement, our schools are running blind with how many students they can add, right, to their student numbers to ensure that we can move that student through their 2-year program, the 4-year program, or 15-month accelerated program seamlessly with enough capacity and placements so they can graduate on time. So that's just a little snippet from Connecticut and what our organization has been involved with. And are our barriers real or perceived? We just have one study of the Hartford Healthcare. Joy, we've yet started to peel back the onion to say, okay, looking at the disparity, you know, are those other 1,200 placements going to be optimal or even possible due to our student populations? So maybe we can't realize everything that they posted, but at least we'll get a greater insight into what questions we need to ask and what capacities and resources our clinical partners need to start building within their organizations, not only to be the clinical placement and stewards for education, but as it goes for their onboarding and also retention strategies. What kind of educators and conversations do we need to have? Why our students are in school and migrating within their organization, so when they land, they're going to be retained. So Our dialogue is just beginning. Some states, I'm sure, are way, way far ahead of us, and we'd really love to hear about that today. So, David, if we're at a good spot, I'd really love to open up the conversation to see if our participants would really like to share either barriers they're facing, solutions and strategies, or other funding potential that really could be helpful to us collectively as we look at this from a huge national scope. I was at a meeting today and everybody thinks, oh, we can steal from New York. Sorry, David. We can steal from Massachusetts. Andrew, if you're on the call, sorry, I can't see you. We can steal from New Jersey, Edna. But I told them we can't steal. Everybody needs the nurses they produce. So excited to open it up. David, would you like to call on people? Would you like me to call on people?
Oh, either way. I do see we have a couple hands up. I believe Jordan raised your
Please.
hand first.
Thank you so much. I wanted to bring up potential funding that you were talking about needing for expansion. We were successful in the fiscal year 2023 budget of getting congressionally directed spending for help with our expansion of our nursing clinical tool. We have a tool that is deployed in like two larger areas of our state that have a lot of the healthcare in our state, but we're not statewide yet, and we'd love to get it to a point where we have a single system and it could be deployed statewide. Right now it's voluntary. We have a lot of partners though that are participating, so I wanted to mention that. And then I also had a question when you were talking about bringing NPs into your system. For us in our state, nurse practitioners are responsible for obtaining their own clinical experiences. So I was wondering how exactly you all are imagining that working, because that it's something that we hear a lot about in our state, students struggling getting those clinical placements. And I was wondering how exactly you plan to tackle that with your all's expansion.
Jordan, thank you for that feedback and thank you for sharing. I think a lot of us are trying to, fill the void and fill the vacuum with innovative programming. So kudos. Related to our schools that offer NPs, most of our schools will actually coordinate and help coordinate those clinical experiences on behalf of their student population. Our state is actually getting a little protective related to our Connecticut nurses going out of state for those NP experiences. A lot of our employers, even though there are nurses, find it challenging to accept other out-of-state programs. So the word is getting out to say, if you're looking for an NP, you may want to stay in state due to that problem.
Thank you so much. So it's very insightful. So the schools would then be responsible for scheduling for the students, though, in your all's expansion. Okay, that's what I had the question about. I was like, how exactly would that work? Okay, thank you so much.
Oh, I was muted. Bad virtual meeting etiquette. Laura?
Yeah, hi there. I'm Laura Smith. I am from Johns Hopkins Hospital in Maryland and Baltimore. And this conversation is, I'm sure everyone's nodding their head, like it's very timely. It feels very urgent to those of us doing this work. And so Maryland, I feel like is kind of similar to Connecticut in that years ago, probably 10 or 15 years ago, we created kind of like a statewide process for a portion of the work. And a majority of the work that I do is with pre-licensure students. So our effort back then was to create just a system to allow hospitals to say, here's what's available, and it allows schools to request it in some type of equitable way. Now, fast forward 15 years, another system purchased that software, and it's just kind of been less. And then obviously with COVID, what we found was that we were all working in silos and that we weren't communicating at all. So just recently, I want to give us, we're proud of this work, but we've just reestablished our collaborative. So we now meet monthly with all of the hospital partners in Maryland, if they can join us, and all of the academic partners. And we're starting from scratch in a way. We're trying to decide on a singular vendor to help with the various process, because I think we would all agree the administrative burden is the worst. And then also being sure that, we're providing equitable opportunities. We are really working to prioritize our Maryland schools too, because we have a ton of schools, we have a ton of hospitals. And so how can we just leverage this? And I loved also your consideration that you shared, Marcia, about how Connecticut also was kind of thinking about how hospitals are like, we need to be more proactive in this on multiple levels. And so we're also considering, what does that mean for clinical instruction? What does that mean for opportunities that we can provide and train up and use our current well-trained staff to then support these students in that manner? So, and also increasing engagement. Like, I think that's another name of the game right now is student engagement. How do we get them involved? And so that's where we are currently collaborating.
Laura, that's wonderful feedback. And just to share with you, something that we did with our Hartford healthcare system. So we don't keep primary documentation of all of the paperwork on our clinical placement system. It's the attestations that our schools sign on behalf, right? But Hartford Healthcare, they wanted to be smart by saying, listen, has anybody worked here before? Most of our hospitals in Connecticut use the Epic, platform. So in the intake form for any Hartford Healthcare property, there's about 30 different questions that they're asking. Have someone done an experience at Hartford Healthcare before? But our system actually tracks that. So my colleague Peg Malik worked almost as an employee of Hartford Healthcare for a couple months. And so we have a wonderful template that they created. They uploaded into their system. So now they know if any student is coming from Sacred Heart, that they don't need to go through the rigmarole, badges, everything. It's all taken care of. So I'd be happy to share with you how they were able to create a lot of efficiencies and not redundancies from the practice side, which was never our intent, but it kind of evolved that way. So yeah.
That'd be great, because I do think there's a piece of lost data from that transition. And so that's something that we're focusing on as well, is like, and we share a lot of students, like we get a lot of returning students because we're a larger state, but we're a little condensed in our area. So that's very good feedback. Thank you.
Great. Joy?
Yeah, I've got a little different view of it, coming from Missouri, which is a very rural state, and a state that has 8 other states that it borders. So where I am, which is Kansas City, Missouri, we have 23 schools that offer an RN degree in the metro area. And so you can imagine that that's a lot of nursing schools with a lot of students and a lot of needs for clinical settings. And then we don't have 23 hospitals. We have fewer. And so as there were more and more schools seeking placements, well over 15 years ago, probably around 20 years ago, the deans and chairs of schools of nursing in the area did get together with the administrations of the various hospitals to create a way to for a more civilized process that didn't make everyone lose their mind, to get clinical sites, and also to standardize the requirements, all of the paperwork, et cetera, that students were required, because we, every single hospital had different requirements. Even hospitals that were within the same system had different requirements. So that was all done mainly with pencil and paper for a long time, but it did work well. One thing that we noticed was that over time, and someone else mentioned this too, you start seeing the cohesiveness fall apart, and pretty soon, oh, well, this system demands these immunizations that no one else does, or this type of, what have you. And we're trying to rectify that. However, again, I'm in one of the 2 large cities in our state. Our state is mainly rural. And the schools that are in the rural parts of Missouri, which are most of them, they have to scramble in order to get clinical sites. They have to beg, borrow, and steal, even sending their students 2.5 hours away to get pediatric experience or to get mental health experience. And that is something we haven't been able to remedy. So anyone else from a rural state, I mean, it sounded so great that to hear everyone in Maryland got together monthly. Gosh, that sounds great. Not possible in Missouri. But
Thank
there's
you.
got to be something.
Yeah.
Yeah. And one other thing I wanted to add, just in case we don't get to there, in our discussion right before we started, and I teasingly said to others from other states who had a lot of applicants that they had to turn away, send them to us. And I will add that encourage them to go somewhere, because I am worried for the survival of my profession of nursing. We don't have enough nurses. We don't have enough people coming into nursing. So try not to hoard.
Yeah.
And try to get everybody. My number one goal is to make my profession survive. So they're there to take care of me in my dotage.
Oh, Joy, thank you for your passion and commitment and sharing. And clearly, as we talked about earlier, New England is such a different story than the heartland of the nation, as well as, California's in a league of its own. I think we have 2 others, David, 2 other hands are up.
Yes, I believe Jennifer's up next.
Well, I'm also from Missouri, not from the metropolitan area that Dr. Roberts is from. I am a department head for a small HBCU in Jefferson City, Missouri, which is the capital city. However, it is still a very rural area. We, like everyone else, struggle with clinical placements, but something that our local schools of nursing have been doing for years is they developed coordinating councils. So there's a Jefferson City Coordinating Council, and then also a Mid-Missouri Coordinating Council that basically all the key stakeholders from the schools of nursing and the hospital education departments meet once a semester. So we'll meet in the spring semester to, outline summer and fall clinical placements. And then we meet in the fall every year to outline the spring clinical placements. And it has worked very, very well. There's not a lot of haggling or fighting over spaces. The issue comes to the table when maybe a new school moves in, or a new program starts, or an existing program increases their numbers. That's when we have to, really kind of work around the table and share and say, okay, well, if this unit, that used to accommodate 14 students is now only able to accommodate 8, how are we going to make that work and share that? We struggle with, every hospital and organization has a different format for submitting student requirements. Some of them, it's an Excel spreadsheet. Some of them use an online program, but we use 4 major hospitals, and all 4 of them use a different type of format.
One thing that I don't know if Joy mentioned earlier, Missouri is unique in the fact that the Missouri Hospital Association offers a clinical faculty academy. Did you talk about that already, Joy? And I know they're hosting one today at one of our local hospitals where they bring in nurses who have a desire and meet the expectations for a clinical faculty member, but they go over, you know, how to have difficult conversations with students, how to, you know, talk to them about expectations. And it's a really, really neat, unique program to help get nurses who maybe have been mentors or preceptors on their unit. They just haven't done it on the academic side, but marrying that. So that's something that the Missouri Hospital Association has been very pivotal in helping get additional nurses to be clinical preceptors. Because that also is a huge need for us in Missouri. You know, when, you know, most of our local schools in the senior practicum, they do preceptorships. So they are paired with a nurse. You know, we usually don't have trouble finding that nurse, but it's when that nurse, her husband has to have emergency surgery, and there isn't another backup maybe, or that nurse breaks her leg.
Right.
And that's when we really scramble.
And Jennifer, those pipeline programs are so imperative. It's wonderful that the Missouri Hospital Association has leaned in to serve as that buffer and that transition. I see we have I'm just trying to just get around to the people who hands. I see Catherine Patterson has her hand up. Thanks for sharing, Jennifer.
Yes, thank you very much. I'm also from Missouri. I am not in I'm in Springfield, Missouri, so I'm not really in Kansas City or St. Louis proper. We only have 2 medical facilities, 2 large health systems in our area. We are a state-run university, so we have to vie for positions with the hospitals. I think this is a bigger problem overall in how we educate, and I see in the chat, you know, a lot of talk about virtual, and so the work environment and what we've experienced with undergrad here is that's not the best locations right now in the hospital setting. There's a lot of barriers, the EHR, being able to log on, being able to give meds, being able to have enough faculty to be with those students. Even if we have a clinical group of 8, only 4 are going to really get to pass meds all at that one time. So we need to, what I think overall in nursing is be willing to look at other avenues. And I saw the virtual thing there. You know, one of the things that I think we've been a little resistant to change, and I'm a diploma grad, and I was in the hospital 3 days a week when I was in St. Louis, and I did my training, and it was the best experience I had. That's not the world these people are living in. Post-pandemic, they're burnt out. There's not enough nurses to go around. Even in their last semester, when they're doing their preceptor-led capstone, it's difficult. It is difficult to get people for it to be consistent. If we're going to bridge that transition to practice gap, we got to start thinking out of the box, man. And I think some of the things that we control, I'm using sim more. I am using virtuals more. I'm not saying that they shouldn't be in the hospital and be familiar, but I think we have partnered with one of the facilities in town, and we do where they, because their staff are so burnt or wanting some release time, they actually have been through the Clinical Faculty Academy, and they take our students, and our students have been incredibly positive when it's a person at the hospital. When it is an employed nurse who's at the hospital working, that then takes them or groups of students, it's much better for them because they're more comfortable. So I think there's a couple things that we need to do here. I don't know that because we've always done it preceptor led and this is how we have to do it, that I think there's other ways to do it. And I think we need to be open to what those other ways are. And that includes a mixture of things. So
Catherine, great comments. And I know in Connecticut, we have some hospitals just aligning OR, and that's what the students are going to do. They're going to get their experience, but they're going to do an intense 9 months in the OR, which is cutting down not only on their orientation once they graduate, but much more structured pipeline. So it's quite interesting, as you alluded to, the innovation between school and practice. And it's really, everybody's out of that. It's not the hospital association driving it. It's not us. It's those partnerships. And, we used to have such robust partnerships, but because people keep changing in the leadership roles, we've never done something foundational and sustainable. And I almost hear that with Laura, the players change around the table, the conversation starts from scratch again. So how can we build foundational structures which will live even beyond when we're gone? Thank you for those great comments. I know, Jill, you've been waiting patiently. Jill Williams.
Hi, thank you. So I'm from Missouri also. We have a great showing as I passed out this information because we've been having these conversations in Missouri. But kind of something I just kind of wanted to throw out there. This is probably like a total pie in the sky thing, but the things that we're talking about, this isn't a national problem. This isn't a state problem or a region problem. We're all struggling nationally with this problem. So, I just can't help but wonder if there's been a conversation at the national level to ever talk about maybe setting some minimum requirements that are a minimum standard that's required for students to do their rotations, or a minimum set of training modules that students have to go to or have to go through. And I think about, the nurses system. Nurses have to register their license through nurses. Is there a system like that where these, students are already using or will at some point use, or maybe there's a different system, but that nationally can be used and accessed by hospitals and schools or whatever that may look like, that at least across the board, there's a minimum set of requirements and training necessary that they would then use. It would be a database that students could go in and do XYZ. The schools or hospitals can access the information just kind of like they do right now with nurses. Would it be awesome to be able to do clinical rotations like that too? So states like Missouri that have 8 surrounding states, we don't have to, go state to state to state to state to whatever system someone's using. We're all kind of using the same system and maybe accessing it in different ways. I just feel like we're all kind of creating, as I hear these stories, it's wonderful that these states are creating their own programs, but we're all kind of working in silos, but we're all trying to do the same thing. So I'm just curious if there's been any kind of talk at a national level about doing anything bigger to help, not solve, but to help with the same problems that we're all facing.
It's funny that you mentioned that, Joe. We had a conversation of our deans and directors and also our chief nursing officers. And we were really looking at how the new essentials are impacting the curriculum. And it was quite interesting that you mentioned that, looking at the competencies. Can we transform our education modalities based on the competencies? And does that look the same as sitting somebody in a classroom? We also had Dan Weberg be a keynote speaker last month at our annual nursing workforce summit. And he was sharing that they were creating a med school where the first year was all virtual, just as you were kind of alluding to, that here are the competencies that are required. You don't need to sit in a classroom. How can we be nimble and transform? So I don't know personally of anything on a national basis, and obviously we'd love to open that up, but you're right on target in what innovations can we now adopt that could be foundational and support everybody. So great.
Well, and I'll add too, like what I'm talking about, I guess, training and education. I'm more thinking on like the hospital side. We have students that go to one hospital and they have to learn how to do hand washing. Well, then they have a clinical rotation at another one and they have to learn hand washing all over again. And they're taking these modules multiple times in order to do their clinical rotation. So what are those, minimum requirements to do a clinical requirements, drug test, BLS certification, or number one. Then number two, what are those minimum set of HIPAA training, hand washing, things like that, that they have to learn in order to do clinicals? And could those be, every nursing student across the nation has this for requirements and this for training. Now, hospitals can do above and beyond that if they like, but these are the set that are required to do to get on board and do a clinical training anywhere in the nation.
Yeah, great idea, great idea. Our hospital association from the health and safety that every single student takes. So not to the extent that you're alluding to, but yeah, the model is churning. Thanks for sharing that, Jill. Laura, I see you have your hand.
I can do two quick follow-ups. One was Jill was mentioning kind of like even a broader kind of view of how we can approach this work. I think that again, until this is where I think COVID was a little bit of a bittersweet situation for our roles, is because we kind of had to force ourselves to be like, wait, what are you doing over there? To do our best to keep the process going, because we still need staff, we still need nurses. So I think that's a bit of a critical point. So I wanted to mention that there's a bit of an organic program that a colleague of mine over at the Johns Hopkins School of Nursing has developed, and she meets somewhat monthly with people across the country regarding the clinical placement process. Now, I think her primary quick initial motivation was to work through the graduate student placements, because many schools have online or remote students. So then they have to find advanced practice placements in various states across the country, and that's become really challenging. So I think that was initially what's brought it off, but through this kind of umbrella, she has these various offshoots, one of which is something that literally they just created, the Society of Clinical Placement Professionals, I think is what they're calling it. And the intent is to more formally kind of bring people doing this work together, what's been successful, what's not been, again, to kind of hold these types of discussions. And I keep saying, and to legitimize the work. I don't know if until recently it didn't feel that there was a lot of value there. So that is something, and I don't know if that's something I can share with David and Marcia. Again, it's really organic right now, but I do know that there's everyone's really motivated. And again, this exact conversation that I'm hearing here is happening there. We're having it at a state level. And then Jill, the other thing I wanted to mention is that something that we have been successful here in Maryland that's off the ground and running is that we created a statewide universal onboarding for students. So clinical nursing students complete one set of modules every 12 months, and hospitals honor that. So they do not remake them do HIPAA, they do not make them do hand washing, they do not make them, and it was a labor of love, there was a little work group that we pulled together everybody's requirements, and we're saying, what's either most important or what's dictated by what accrediting body, what, and I think there's 12 modules that we have the students do when they start the program. And then again, and that's again, kind of where we're getting our collaborative back together, because we were okay, we have a little momentum. And so we're trying to heat it. So it was laborious, but that's been successful at a state level. It's again, the implementation's not perfect, but I think it can be done, but it is, unfortunately, it's a very organic thing. You kind of have to just get it from a grassroots kind of effort to begin all the spreadsheets. But again, and we can share more about that in some other forum. But I think if you start at a state level, it might feel a little bit better. But I completely see what you're saying, that at some point these students will cross lines, and I think that makes sense, especially in New England when they're all so tight anyway. So.
Can I ask a quick clarifying question? So I'm new to this group, and this has been very helpful. Laura, do you mind sharing with what organization you are and how large that geography was that you consolidated?
So I'm from Maryland. I work at Johns Hopkins Hospital. So I'm the placements coordinator for the hospital. And it kind of began through our Maryland Organization of Nursing Leaders, and then our Maryland Nursing Workforce Center. They kind of helped put a little umbrella over the work. And then the rest of us just kind of met somewhat regularly. We pulled all of our requirements and we researched our peers' requirements, a lot of surveys, a lot of forms. But what was your question again? I'm so sorry.
That's just helpful. I'm just trying to, that's exactly, I'm from Ohio and Cincinnati, the Health Collaborative, where we pull together all the hospitals and do health improvement, et cetera. And we have a ton of workforce stuff going on. So it's the right thing to do. It's just how big of a geography did you consolidate?
So
Understanding these roles of everyone.
I
who's
see
on
what you're
here.
saying. So we essentially did the state. Now, I'm not going to say that every clinical facility. So we primarily focused on hospitals and probably some of the more regular clinical placements. And again, we also focus primarily on the pre-licensure program. I think a majority of it will translate pretty easily to advanced practice students. But again, we tried to just like find one little umbrella. And technically, like every CNO and dean and director heard about it at one of the meetings. And so it's kind of a more of just of like, are you aware of that we're doing this? And here is the information that my students have completed this. And in most cases, hospitals are accepting it via an attestation, via, and so what we challenge us now is that many hospitals need to be sure to like review the requirements and take things out. So that's kind of still where we are in the implementation portion of it. But it did technically, like we reached the state. And again, I'm trying to think about, like, I'm thinking long-term care facilities, maybe not involved. Head Starts or like other types of clinical placements, we're not probably involved in that. So if that helps kind of clarify the scope of it a little bit.
Laura, thank you very much. And Deidre, great question. And, as I'm hearing all the different organizations that are being talked about, so for those who are not involved with their hospital associations in their state, they need to call and Google their hospital association. Many are either working at it at the macro level through the trustees and looking at positive workplace cultures and everything that goes into that, or they have a specific workforce. If you have not worked with your workforce development boards, they used to be called workforce investment boards. We're a small state, so we have 5 of them. They have lots of money to give out. We were given over $300,000 to create a new CNA course specifically to long-term care. This came about due to our long-term care facilities had a very challenging time with COVID. CNAs left in droves. We needed to get more CNAs in. And so the competencies had never been really assessed in recent vintage. So what our CNA courses in Connecticut, we have over 126 of them we're producing, really weren't meeting the current needs. So workforce development boards, if you have not played with them. So we have a lot of American Rescue Plan money still in the state. Our small state of Connecticut almost got $1 billion. Clearly that was for people affected by COVID, but also for healthcare facilities, institutions, your state agencies. So I would start with your Department of Public Health or your Board of Nursing. They will know all of these pockets of money that came into your state. Most are focused in on nursing and nursing workforce development. For those who are involved in career pathways, and Joy, I heard you loud and clear, how are we going to groom, the elementary, middle, high school students with so many options to find that healthcare has roles and there's so many different type of roles, how could they, lend their talents, etc. So again, our workforce boards and our school districts are doing yeoman's work through our Department of Higher Education in Connecticut with building pathways, again, lots of dollars. And then this morning, our workforce development boards created what's called regional sector partnerships. And this is through the Federal Department of Labor has been giving our states money. And the way our state is pushing it out is through our workforce boards. And they're convening employers, community, and academicians to say, in the greater Hartford regions, what's happening. In rural Connecticut, and we have very rural Connecticut, another group, what's happening. And they're finding out it's more about transportation and wraparound services to sustain residents in any kind of education related to healthcare due to, as you all mentioned, you've got the clinical component as part of the undergraduate process or a CNA course. Lots of people can't pivot and go to an immersion. So again, workforce development board, share what you are to them and where you can plug in and play. Again, they're the ones who attract the money. Anybody else? I know we have probably about 10 minutes left before we close. If we're looking at funding, has anybody in any state received either state or federal funding, or private philanthropy, and I'll share with you after the discussion, we got a nice chunk of private philanthropy to do a special project. Anybody on that? You can raise your hand or just unmute yourself. I think funding is important.
Yes, in Missouri, they had several funds, several pots of money for significant awards to increase the nursing workforce in particular.
Jordan,
Our governor, during when all that COVID money was coming into the states, dedicated $48 million to nursing workforce development. So that went to, a lot of it went to education, and we are doing a 4-year project that expands all pre-licensure programs in the state. By 20 students for RNs, 10 students for LPNs. We don't have very many LPN programs participating. But after the federal funds right now, we've now received the 2nd year funding from the state, and the state is talking about continuing to fund it for 4 years, but of course it's going to be on a year-to-year basis. The rest of that money went to, we had nursing faculty investment incentives. We took care of licensure fees with that money. And we've done just a couple of other smaller things, working on recruiting nurses from other states into the state with financial incentives and things like that.
so Jordan, that's coming out of your Department of Public Health, your Economic Development, your Office of Higher Education. Do you know what agency?
So it's coming from the, it's coming into the West Virginia Higher Education Policy Commission, and then kind of going, most of the money went that way. Now, there was a little bit of the money that went directly to our Department of Health and Human Resources, but most of it went to higher ed.
So those are some names you want to look at within your state. Any
Mhm.
other state, I know we have quite a smattering of folks, have heard about dollars being available in your state, even if you didn't access them, or were any of you awarded dollars? Interesting. And that also goes to, I think, what we've heard from, Jill and Laura and Joy, being part of the conversation and getting involved in these conversations. Again, we were the Connecticut League for Nursing for 70 years. We were the Connecticut Workforce Center for 10 years. Last year, we made a formal merger. Now we're the Connecticut Center for Nursing Workforce. I've been around in healthcare for over 30 years, started at the Hospital Association in the late 80s, but still people are just finding out about us. We have an online Connecticut nursing guide, which lists every nursing school and program in the state, including LPNs, every single track of masters, every postmasters and doctoral program, pre-licensure. We go to the high schools, we give it out of workforce development boards. And I was at a meeting today with new people at different hospitals and community organizations, and about half never heard of us before. So it's so interesting that even though we think people should know about us or what our school does or the innovation, Laura, that's happening, or as Jill, you're putting all these innovations together, we do continually need to market ourselves within our state, so not only they know who we are, but they know what we do. I just ran across this organization that's been funded through Yale University for 10 years, and it's actually the 4M model to support senior care. I've been around for a while. I never heard of them. They never heard of me, but now we're embedding their wonderful curriculum into our CNA program. But it's just so interesting how many of us, because I see some names on here that I've been familiar with for quite a few years, Jana, that we think that we're plugged in, really taking time to reflect and saying, who are the players in our state and what's our story now? Because they may have known you, Jennifer, in a totally different light before than your role now. And so what can we do to really share? So again, as we kind of look at the overall Barriers and challenges, I think we've identified quite a few. Everything from simulation to clinical placement to silos to, inconsistent paperwork. I did put in the notes related to the paperwork for students and other things. Many times it's the legal department that makes a broad stroke to say, everyone should do this, but not understanding the negative unintended consequence that's impacting over 7,000 students, whether they be nursing, medical assistant, trying to do clinical experiences, and the cost of what they ask. They think fingerprinting. They don't realize in the state of Connecticut, it's not electronic. The person's got to get to a state police barracks. Who has time to do that? And by the way, it's only 3 hours on a couple days a week. So all of a sudden, we really need to, I think, educate our partners to share. We understand this is important, but can this be done through a better way, a better system? And then I hear what Laura was saying. Once people are in the system, and Jill, once people are in the system, how can that information and data be transported, transferred, or accessed systematically to reduce duplication? So I think we have so many opportunities to really look at this. And you're right, Jill, it is a national issue. And if we can't get our arms around to coming up with, number one, common language. What we realized this morning, we had a meeting of all the disparate pieces and parts. People from practice don't talk academe, then talk labor and talk education. Everyone was this way, but we're all talking about the same thing. So really, common language and what is going to make the greatest impact. And sometimes it is financial resources because we need to create something, and sometimes it's not. But let me just share with you, we in Connecticut applied for the federal DOL grant for nurse faculty expansion. It was due in January. We just received a no 2 weeks ago, and we were looking at nurse faculty expansion. We had galvanized over 40 practice settings, specifically in the long-term care space. We galvanized all of our state agencies. When I sent out the sad note, you can uncross your fingers, we didn't get it. The people who responded really understood what the impact of that was going to be. So again, we didn't have a successful outcome, but boy, did we create some great partners. And then lastly, starting to reach out to private philanthropy, much more nimble and easier to access than these big state and federal grants. We were awarded $300,000 to create a full-time nurse faculty prep course. Our schools were finding that we have brilliant DNPs and PhDs coming into the academic setting. They don't know how to teach. To onboard them and structure their learning, the professional wasn't really comfortable until year 2. How could we reduce that? So we actually got our best minds together and said, okay, this is how we can prepare them. We have a foundational book, the whole schmeal. We're piloting it. We're in week 4, but we're learning so very much in addition to the course in and of itself, but how to effectively onboard the next generation of nurse educators. We'd be happy to share all that. And the funder said, because I've been giving them the progress reports, they actually want to fund a 2 to 3 year study. And I think this is what lends itself to David, the Center for Health Workforce Studies. What can we do to almost evaluate our efforts to share what is working and what's not working so we can all learn to fail quickly and innovate quickly, or innovate in a positive direction. So I know we have a couple minutes late. Would love to hear anybody's final thoughts, but I think the discussion and the transparency, thank you for sharing. I think this has been an amazing conversation. Anybody for the good of the cause before we close?
This is Deirdre from the Health Collaborative. I found this very helpful. We've recently kicked off the Southwest Ohio Educators and Healthcare Educators and Workforce Coalition just to bridge all the different pieces together. And we found tremendous positive responses because there isn't kind of that kind of coalition of pipeline from employers to middle school. And so anybody else who's doing that work, I would love to connect with, because we just started it in January. We have submitted ARPA grant to the governor to expand nursing and LPN pipeline through that work, bringing our career techs or workforce boards, et cetera. But anybody else doing that work at a regional level so we can share best practices?
The West Virginia Center for Nursing has a model that we fund. Like we have a small grant program and we created a model that's used statewide. And it's like they do little nursing career academies and they can do it at the middle or the high school level. And we kind of provide the core resources for them to build their program and then give them a little bit of seed money to get them started. And then usually the hospitals will kick in and they have a partnership with a hospital and they end up kind of running with it. We have ones that have been going for a long time, and we're seeing those students matriculate into the nursing programs now.
Marcia, do you have any closing thoughts, comments?
No, I'm just so excited to hear how everybody's doing different things in different states because we know one size doesn't fit all because of our inherent geography and or barriers. So it's great to hear all the diverse ideas and strategies and opportunities for funding for moving forward. So David, thank you for you and your team, Matt and Trish, for putting this on. It's been a wonderful conversation and really appreciate you supporting the forum and in our efforts to continue the dialogue beyond our organization. So thank you.
Oh, and thank you. It was a wonderful conversation. And thank you, everyone in the audience, for contributing.